Hi there. My name is Carolyn Calfee, and I'm a professor of medicine and anesthesia at the University of California, San Francisco. And I'm delighted to have the opportunity to talk with you today about ARDS subtypes based on inflammation. Thanks to the organizers very much for inviting me here. These are my disclosures. So we can think about many different ways to phenotype or to subtype ARDS, much as there are many different ways to slice an onion. Traditionally, this has been done in ways that are what I call clinically obvious, using the differences that we as clinicians observe at the bedside. For instance, ARDS risk factors, trauma versus sepsis, direct versus indirect, severity, mild, moderate, or severe, radiographic appearance, diffuse versus focal, and most recently, of course, etiology in COVID-19 versus typical ARDS. And each of these may certainly have value to them. But I'd ask why we seek phenotypes. What is the goal of seeking to split ARDS into smaller subsets? Well, I would argue that the reason that we're doing this is because we're looking for differences in treatment response. We're looking for a treatment responsive subgroup, because otherwise, why does it really matter how we split these patients unless they respond differently to therapies? And I think in part this search has really been motivated by the fruitlessness of our search for an effective pharmacotherapy for ARDS. This is just a partial list of some of the many drugs that have seemed to be effective in early phase animal studies, in early phase clinical trials, and yet have failed to translate consistently to effective benefit in our patients. And so the hypothesis here is that reducing some of this heterogeneity or splitting more thoughtfully might solve the problem. So the question is, how do we do this intelligently? What's the best way to slice the onion? We can, again, many different ways to approach this here. But one approach that our group has taken and that I tend to favor is a data-driven approach. So what is the data showing us in terms of a particular pattern? Is there evidence from the data that suggests discrete subgroups? Now, Lua Boss's group has done this using an approach called cluster analysis, in which they've clustered plasma biomarker data and identified two discrete subgroups, which they've termed reactive and uninflamed. The reactive group has higher biomarker levels across the board in general, as well as higher mortality. We've taken a different data-driven approach called latent class analysis, which seeks more homogeneous, distinct subclasses within a broader group of patients and asks whether the distribution of data, as you can see, for example, on the right-hand side, better fits with the hypothesis that this is one group, two group, or perhaps, as you see in the dotted line, three groups of patients. And this approach can be applied to data completely independent of clinical outcomes, for instance, clinical and biomarker data at the onset of enrollment in a clinical trial or observational study. And that's how our group has taken this approach into ARDS, looking at clinical and biomarker data, biomarkers of inflammation and injury, in 5 randomized controlled trials, plus 2 observational cohorts, totaling now over 4,000 patients. And in all 7 of these data sets, we see strong statistical evidence that a 2-class or 2-phenotype model is a better fit for the data than a 1-class model. When we compare these 2 phenotypes, we see that one of them is characterized by higher plasma levels of inflammatory biomarkers like IL-6 and IL-8, TNF receptor 1 and PI1, and lower levels of bicarbonate, protein C, and systolic blood pressure. And so we've termed that class that's characterized by the higher biomarkers of inflammation hyperinflammatory, and it consistently represents about 1/3 of the patients, in contrast to this hypoinflammatory group, which is consistently about 2/3 of the patients. We see that this phenotype is stable over several days in both the ARMA low tidal volume trial and the alveoli low versus high PEEP trial. We see again that 2 classes are present on study day 3, and that about 94 to 95% of patients stayed in the same class from day 0 to day 3. So in this table here from alveoli, if you were in class 1 on day 0, you had a 95% probability of being in class 1 on day 3. And that's of course important that phenotype is somewhat stable if we're thinking about targeting it in clinical trials. We can see that across all 7 of these studies that I've described, 90-day mortality is dramatically higher in this hyperinflammatory group, both numerically and statistically so. And that's true from studies dating from the mid-1990s, like the ARMA trial, through studies that concluded more recently in our observational cohorts just a few years ago. But we've been particularly interested in this work because we think we may have identified a treatment responsive group. Now, I want to emphasize that this is all secondary analyses of randomized controlled trials, but nevertheless, these latent phenotypes appear to respond differently to high versus low PEEP, to conservative versus liberal fluid status, and to simvastatin versus placebo. But this is all secondary analysis. Prospective confirmation of differential response is, in my view, really imperative before we change clinical practice. We've developed biomarker-based and clinical data-based classifier models for prospective testing, as well as a roadmap for trial design. And if you're interested in more details on this, I'm giving a related talk in a separate session in this meeting. The session is entitled Reducing Heterogeneity in ARDS, Subphenotyping, or a New Definition. But today I'm going to focus on something slightly different. I'm going to show you some new evidence that suggests that these inflammatory phenotypes that we've described are actually relevant in COVID-19, as well as some interesting, intriguing evidence for differential treatment response by phenotype in patients with COVID-19. Now, this is collaborative work that's been done with colleagues at Columbia and Washington University. In particular, I want to highlight the efforts of the two junior folks who were the first authors of this work, Pratik Sinha from WashU and Dave Furfaro from Columbia, now Beth Israel Deaconess in Boston, as well as the senior authors along with myself, Max O'Donnell and Dan Brody and Jeremy Beitler, all from Columbia. And what I'm going to show you is latent class analysis in patients with COVID-19 related ARDS. Now, the cohort I'm describing is 483 adult patients with COVID ARDS that were enrolled in the spring of 2020, all at Columbia University Medical Center. So just wrap your heads around that for a moment, that almost 500 patients were enrolled at one medical center in the course of 2 months. The mean age of these patients was 65. The majority were male, and reflecting the disproportionate impact of the pandemic in the U.S. on communities of color, as well as the patients served by Columbia, you can see that the majority of the patients in this cohort were either Hispanic, Latinx, or Black. And overall mortality was quite high, 54%. So we used latent class analysis, as I described to you before, on clinical and biological data from the first 24 hours of intubation. The list of the variables we used in the latent class analysis is provided here on the right-hand side of the figure, and I just want to emphasize that we did include a number of respiratory variables that have been hypothesized to identify discrete subgroups within patients with COVID ARDS, including PF ratio, PEEP compliance, and ventilatory ratio, as well as a number of inflammatory biomarkers, but really only one of the sort of research type biomarkers that we've described in our prior work, that's IL-6. Now, this table here describes the fit statistics of a latent class model, and I'm going to focus on the key points for you. Each row is a specific model, 1 class, 2 class, 3 class, or 4 classes. The BIC is a measure of model fit. It goes down as the fit gets better, and you can see that there's quite a decrease from a 1 class to a 2 class model, with smaller decreases hereafter. Entropy is an index of how well the classes are separated. Values of 0.8 or greater indicate good class separation, so you can see we have good class separation across these different models. The N's are the number of patients in each of the classes, and this p-value compares this number of classes to 1 fewer. So you can see that we have a significant improvement in fit going from 2 classes to 1 class, but not from 3 classes to 2 classes. So we concluded on the basis of all of this data that a 2-class model was the best fit. What did these 2 classes look like? Well, this is a similar figure to what I showed you before. I'm going to go through it in a little more detail here. These are the continuous variables shown here on the x-axis, sorted from maximum positive difference between the classes on this side to maximum negative difference on this side. And so the variables at the extremes of the figure are those that really separate the classes well. And what you can see here is that the smaller class, class 2, is characterized by higher levels of inflammatory biomarkers like lactate, troponin, procalcitonin, higher creatinine, higher LDH and heart rate, as well as higher IL-6 and ferritin. It's also characterized by lower levels of platelets, albumin, and bicarbonate. Interestingly, the respiratory variables were here in the middle, indicating that there was not much difference between the 2 phenotypes in these variables. This is just showing the same data in a slightly different way, which is to say that comparing the two latent classes, there was really no difference in the P to F ratio and no difference in compliance. So this did not suggest that there were distinct subgroups within COVID ARDS that are distinguished on the basis of their compliance. Now, how do these phenotypes correspond to the typical ARDS latent phenotypes that I've shown you before? Well, what we did is applied a clinical classifier model that uses clinical variables only to identify the latent ARDS phenotypes. We published that model last year in the Blue Journal. Using that model, we found that about 30% fell into the hyperinflammatory ARDS phenotype, and about 70% fell into the hypoinflammatory phenotype. This diagram at the right-hand side is a Sankey plot that shows the correspondence between these typical ARDS phenotypes on the left and the COVID ARDS phenotypes on the right. And you can see that while there is some crossover between these phenotypes, most of the hypoinflammatory patients were in the COVID ARDS class 1, and most of the hyperinflammatory ARDS patients were in COVID ARDS class 2. All right, how did these phenotypes relate to outcomes? Well, what we found is that when we classified patients using these latent classes within COVID ARDS, class 2, that class characterized by the higher levels of inflammatory plasma biomarkers, had dramatically and significantly worse mortality as well as ventilator-free days. Similarly, when we classified the patients using the clinical classifier model into typical ARDS phenotypes, that hyperinflammatory group also had numerically and significantly worse mortality and more time on mechanical ventilation. But what was perhaps most interesting to us was when we asked whether there was evidence of differential treatment response to steroids. Now, I want to emphasize here that in contrast to the prior data that I've showed you, this data does not come from randomized control trials, so steroids were not randomly assigned. However, they were equally administered across the phenotypes, so about 2/3 of patients in each of the phenotypes received steroids. And what did we find? Well, we found that if we use the typical ARDS phenotyping strategy, patients in the hypoinflammatory group seemed to do worse with steroids, higher mortality at 90 days, in contrast to the hyperinflammatory group, where mortality was lower in patients treated with steroids. And this p-value here is the p-value for interaction, treatment interaction, meaning that the effect of the treatment differed on the basis of phenotype. When we asked the same question using the COVID-related ARDS classes derived from the latent class analysis, we found a similar pattern. Really no difference in mortality in that larger class 1, but in that class characterized by the higher levels of inflammatory biomarkers, we found a dramatic mortality reduction in patients treated with corticosteroids. And again, the p-value for interaction was significant, suggesting differential treatment response. So this has been really intriguing to us. We have wondered for some time if this moniker of hyperinflammatory for this smaller phenotype was actually accurate. This data suggests that it might be, though many, many questions remain to be answered. Interestingly, cycle threshold, which is roughly reflective of viral load, was prognostic only in the hypoinflammatory phenotype. So in the hypoinflammatory phenotype, having a lower cycle threshold, which translates, of course, to a higher viral load, was associated with higher mortality, and we did not see this pattern in hyperinflammatory phenotype, which might lead one to hypothesize that perhaps it's the inflammation that's related to mortality or the host response here. And in contrast, it's the viral load here. That's really taking it a little far in terms of hypothesis generation. So to summarize this data that I showed you, we see that latent class analysis identifies 2 classes of COVID ARDS with a high degree of overlap with typical ARDS phenotypes. Mortality is higher for this hyperinflammatory COVID ARDS. And hyperinflammatory ARDS and COVID ARDS class 2 may preferentially respond to corticosteroids, though with the caveat that steroids were not randomly assigned here. A couple of other important caveats. This was the first wave of COVID in New York City with a very high mortality. Many of these patients were treated with hydroxychloroquine and relatively few with remdesivir. But I think this certainly supports the hypothesis that treatment responsive subgroups might exist within COVID-19 ARDS. All right, so where do we go from here? Well, I think we have many unanswered questions. The data that I've shown you is largely hypothesis generating. I think the first hypothesis being that patients with ARDS can be divided into two phenotypes described by clinical data and biological markers, and these two phenotypes have divergent clinical outcomes. I think we can consider this hypothesis now to be confirmed, that we've repeated it in 7 different data sets with over 4,000 patients. But there are many other generated hypotheses that are in need of testing, including that these two phenotypes respond differently to treatments, including PEEP, fluids, simvastatin, and corticosteroids. These two phenotypes differ primarily on the basis of inflammation. And perhaps most provocatively, that these two phenotypes may not be phenotypes of ARDS per se, but are phenotypes of critical illness. These questions, in my mind, remain unanswered. So the take-home messages of the talk: we see strong statistical evidence of these two ARDS phenotypes in 5 randomized controlled trials, 2 observational cohorts with widely divergent clinical outcomes, and in secondary analysis, differential response to PEEP, fluids, and simvastatin. We have new data that 2 similar phenotypes exist within COVID ARDS and may respond differently to corticosteroids. But we have many unanswered questions, and I think prospective confirmation is really essential before we change our clinical practice. So for more on the next steps, I'd encourage you to watch the session on reducing heterogeneity in ARDS, where I'm going to talk more about those topics. Thanks very much.